Hi, hello everyone. Welcome to Dr. Ravichandra Official. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos on pathology. In the previous videos, we have discussed what is anemia, what is the classification for anemia, what are the signs and symptoms of anemia, and what are all the investigations to be done to differentiate various anemias, and what is microcytic anemia, and what are all the features that are seen in iron deficiency anemia, and what are the treatment modules that are used for iron deficiency anemia? In this video, we will discuss macrocytic anemia and B12 deficiency and folic acid deficiency and pernicious anemias. Before going into the topic, we should know what is a microcyte, what is a macrocyte, what is a megaloblast, what is the morphological classification of anemia, what are the normal values of B12 and folic acid, where they are present and what their function, and then we will discuss megaloblastic anemia. Microcytic hypochromic anemia and macrocytic anemia together, if present, then it is called as dimorphic anemia. Nutritional anemias include iron deficiency anemia, B12 deficiency anemia, and folic acid deficiency anemias. So this is a picture showing the red blood cell. Normally, the red blood cell will be biconcave in shape and its size is around 7.5 microns, which is equal to the size of a nucleus of a small lymphocyte. If it is less than the 6 microns, then it is called as microcyte, and if it is more than 9 microns, it is called as macrocyte. Morphological classification of anemia is divided in based on the size and the red blood cell index MCV, normocytic anemias, microcytic anemias, and macrocytic anemias. In normocytic anemias, MCV will be within the normal range 80 to 100 femtoliters. And in microcytic anemia, the MCV will be less than 80 femtoliters. And in macrocytic anemias, the MCV will be more than 100 femtoliters. Microcytic hypochromic anemias, differential diagnosis is, remember the mnemonic CETA. S for sideroblastic anemia, I for iron deficiency anemia, T for thalassemias, A for anemia of chronic disease. Macrocytic anemia, it can be megaloblastic anemia or non-megaloblastic anemia. Non-megaloblastic anemia includes liver diseases, hemolytic anemias, alcoholism, myelodysplastic syndromes, hypothyroidism, and megaloblastic anemia is because of B12 deficiency and folic acid deficiency. For macrocytic anemias, you can remember the mnemonic A, B, C, D, E, F. A for alcoholism, B for B12 deficiency, C for cirrhosis of liver or liver disease, D for drugs like phenytoin, methotrexate, uh, and other drugs, E for endocrine problem, that is hypothyroidism, F for folic acid deficiency. Coming to the normocytic normochromic anemia, here the MCV is 80 to 100 femtoliters. It can be differentiated further based on the reticulocyte production. If the reticulocyte production is normal, then it is because of the recent blood loss or hemolytic anemias. If the reticulocyte production is deficient, then it may be because of the aplastic anemia or myelopathic anemia, or chronic renal failure, or anemia of chronic disease, or hypothyroidism. These are this in this picture we are able to appreciate the microcytes, macrocytes, and normocytes in various peripheral blood smears. In the last picture, you can even appreciate the sickle cells, which is a seen in sickle cell anemia. So this is one more illustration showing the classification of anemias according to MCV. So for high reticulocyte count, remember the mnemonic shape: S for sickle cell anemia, H for hereditary spherocytosis, A for autoimmune hemolytic anemia, AIHA, P for paroxysmal nocturnal hemoglobinuria, that is PNH, and E for enzyme deficiency, out of which the glucose 6 phosphate dehydrogenase deficiency, that is G6PD deficiency, is the most important one. For the low reticulocyte count, it is the mnemonic Ramco or Ramchandra or CRAM, whatever it is. C for cancers, all the metastasis or leukemias. R for renal failure, A for anemia of chronic disease, and M for myelofibrosis. Coming to the features of B12 and folate. B12, it is present in meat. It is the rich source. Next to meat, it is the milk, that is good source for B12. And vegetables are poor source of B12. Whereas folates are rich in vegetables, moderate in meat, and poor source is milk. On cooking, there will be 10 to 30% loss of B12, whereas 60 to 90% of loss will be there of folate. Daily requirement for B12 is 2 to 4 micrograms, whereas folate is 200 micrograms. Adults' daily intake will be 5 to 30 micrograms of B12 and 100 to 500 micrograms of folate. Site of absorption for B12 is ileum, whereas site of absorption for folate is duodenum and jejunum. B12, ileum, and folate, duodenum and jejunum. Body stores of B12 will be 2 to 5 milligrams, which is adequate for 3 years. And for folates, body stores will be around 5 to 20 milligrams, which is adequate for only 4 months. When the food has been taken, food with protein bound vitamin B12 in the form of adenosyl cobalamin and methylcobalamin will be released into the stomach or enters the stomach. There, the acid and pepsin in the stomach will do proteolysis, thereby releasing the B12 from the protein bound molecules. And this will combine with the gastric R protein. R protein is derived from saliva. It is also called as haptocorin. R protein is derived from saliva and also gastric juice and has a greater affinity for the B12 than intrinsic factor. So B12 first enters into the body with the help of binding with haptocorin, then with the help of proteolysis of because of the acid and pepsin, it gets detached and it will attach to the R protein and forms a complex. B12 R protein complex is cleaved by the pancreatic enzymes in small intestine. And again, this liberated B12 will combine now with the intrinsic factor, which is secreted by the parietal cells in the fundus and body of stomach. Now this intrinsic factor B12 will bind to the receptors on brush borders of the ileal mucosa in the presence of calcium. when the pH is more than 6. And the intrinsic factor is destroyed in the ileal cells, and B12 will bind to transcobalamin 2 to be released into the portal circulation. From there, it is distributed to the tissues as holotranscobalamin. Further cellular uptake of B12 via the megalin or transcobalamin 2 receptor complex will occur. Simply to remember, the food consisting of vitamin B12 will be attached with the protein bound complex in the form of adenosylcobalamin and methylcobalamin. When it enters the stomach, because of the acid and pepsin, there will be proteolysis, and this protein bound complex is separated and B12 is released. With this B12, the R protein derived from saliva and gastric juice, that is haptocorin, will form a complex, B12 R protein complex, and enters into the small intestine. In the small intestine, pancreatic enzymes will cleave the B12 R protein complex and release the B12. The intrinsic factor that is secreted by the parietal cells in the fundus and body of the stomach will now attach with this B12 and form a complex. Intrinsic factor B12 will bind on to the receptors on brush border of the ileal mucosa in the presence of calcium. Remember this point. Intrinsic factor is destroyed in the ileal cells, and again this B12 is released. Now this B12 is carried by transcobalamin 2, and it will be released into the portal circulation. And this again this B12 is distributed in tissues as holotranscobalamin. Further cellular uptake will be taken with the help of megalin or transcobalamin 2 receptor complex. This is B12 metabolism. And for the formation of succinyl-CoA from methylmalonyl-CoA, we need methylmalonyl-CoA mutase and adenosylcobalamin B12. So B12 is needed for the formation of succinyl-CoA from methylmalonyl-CoA. This is one important conversion. And for the formation of DNA, DTMP is required, and for the DTMP to be formed, DUMP has to be converted to DTMP in the presence of N510 methyl tetrahydrofolate, and N510 methyl methylene tetrahydrofolate is formed by methylation from tetrahydrofolate. Tetrahydrofolate is formed from N5-methyl tetrahydrofolate by releasing the methyl group. With the presence of this methyl group, the homocysteine is converted to methionine in the presence of methylcobalamin. So, in this whole process, we need folic acid and B12. For conversion of homocysteine to methionine, B12 is required, and for the formation of DTP from DUMP, we need folate. So, deficiency of B12 will lead to increased levels of methyl malonyate and propionate in the first reaction when there is no formation of succinyl-CoA. Thereby, synthesis of abnormal myelin lipids will occur. Thereby, myelin degeneration and neurological abnormalities will be seen in the person with B12 deficiency. In the second process, there will be impaired DNA synthesis, and there will be trapping of folate as methyl tetrahydrofolate. So this will result in folic acid deficiency without neurological symptoms. The polyglutamates that are present in the food are converted to monoglutamates with the help of the conjugases present along the brush border. And these monoglutamates are converted to methyl tetrahydrofolate by reduction and methylation. The DUMP, that is deoxyuridylate monophosphate, is converted to deoxythymidylate monophosphate, and it is further helpful in formation of DNA. So the thymidylate synthetase will help in this process. And homocysteine is converted to methionine in the presence of vitamin B12 with the help of the methyl group released from the plasma folate, methyl tetrahydrofolate. So when there is folate deficiency, the conversion of DUMP to DTMP is not possible. Thereby, further there will be defect in formation of the DNA. As a result, there will be folic acid deficiency causing the macrocytic anemia. So, with this brief introduction, we will start the macrocytic anemias. Macrocytic anemias can be megaloblastic anemias or non-megaloblastic anemias. Megaloblastic macrocytic anemias, in this type, megaloblasts are seen, which are erythroid precursors seen in the bone marrow due to abnormal DNA synthesis. Vitamin B12 deficiency, folic acid deficiency, myelodysplastic syndromes, chemotherapy effects will cause this megaloblastic macrocytic anemia. Non-megaloblastic macrocytic anemia, in this type, there are no megaloblasts seen in the bone marrow. That's why it is called as non-megaloblastic anemia. Seen in liver disease, hemolytic anemias, alcoholism, hypothyroidism, and in few cases of myelodysplastic syndrome. Remember the mnemonic A, B, C, D, E, F. A for alcoholism, B for B12 deficiency, C for compensatory reticulocytosis, that is blood loss and hemolysis, D for drugs, cytotoxic and agiotropyrin and dysplasia, marrow disorders, E for endocrines, that is hypothyroidism, F for folate deficiency or fetus when the mother is pregnant. So A, B, C, D, E, F. A for alcoholism, B for B12 deficiency, C for compensatory reticulocytosis, D for drugs, E for endocrine problem, and F for folic acid deficiency or fetus in pregnancy. This is the picture showing the macrocytes. So with the small lymphocyte, the size of the red blood cells when compared, they are more in size. And if you observe, there are few ovalocytes also there in the peripheral smear. So this is a peripheral smear picture of macrocytic anemia. Anisocytosis is there and poikilocytosis is also observed. Anisocytosis is change in the size and poikilocytosis is change in the shape. This is one more picture showing the macrocytic anemia. In the lower picture, if you observe, there is a hypersegmented neutrophil. That is, normally the neutrophil will have 3 to 5 lobes. If it is more than 5 lobes, then it is called as hypersegmented neutrophil. If a single neutrophil is having hypersegmented neutrophil with more than 6 lobes, it is enough to diagnose it as a megaloblastic anemia. Or if the hypersegmented neutrophils are having more than 5 lobes and around more than 5% of the neutrophils are showing this feature, then also it can be considered as megaloblastic anemia. So macrocytic anemia with no megaloblastic changes is non-megaloblastic, and with megaloblastic changes and bone marrow is megaloblastic anemia. When we see the reticulocyte count, it will be low in megaloblastic anemia, and the patient will respond to vitamin B12 supplementation and folic acid based on the deficiency. In the non-megaloblastic anemias, if the high reticulocyte count is probably hemolytic anemias. If it is low reticulocyte count, then it is liver disease. Macrocytic anemia, as I said earlier, the MCV will be more than 100 femtoliters. If we see oval macrocytes in the peripheral smear, then it is oval macrocytosis. If we see round macrocytes, then it is round macrocytosis. Oval macrocytosis is seen in megaloblastic anemia, myeloproliferative disorders, myelodysplastic syndromes. And with the help of bone marrow aspiration, we can differentiate the further these three conditions. And B12 and folic acid deficiency will cause oval macrocytosis. Round macrocytosis, there will be polychromatophilia and it is seen in hypothyroidism, scurvy, and we have to do further appropriate investigations to rule out these conditions. So this is a picture showing a macrocyte, microcyte. Erythroblast is normal precursor cell of a erythrocyte, whereas megaloblast is precursor of a macrocyte. So in the 3 marks question, they may ask you megaloblast question. So for that, you have to define what is a megaloblast and you have to compare the differences between the erythroblast and a megaloblast. So cell size and nuclear size will be normal in erythroblast, whereas it is larger than the corresponding stage in a megaloblast. The nuclear chromatin and nuclear maturation are normal in erythroblast, whereas the nuclear chromatin is light and open even in the late stages, and the nuclear maturation will lag behind in late stages in a megaloblast. Mitosis is normal in erythroblast, whereas it is frequent and abnormal in a megaloblast. Cytoplasmic maturation is normal in erythroblast, whereas it is unaffected, just like erythroblast in a megaloblast. Color of the cytoplasm, it is normal for the corresponding stage in erythroblast, and it is also similar in all the megaloblasts. You can clearly see the picture showing a normoblast and megaloblast, how the size and nuclear features are varying in both the conditions. Now we will discuss megaloblastic anemia. Nutritional anemia with B12, vitamin B12 or folic acid deficiency is called as megaloblastic anemia. Etiology: vitamin B12 deficiency, folic acid deficiency. Vitamin B12 deficiency is because of inadequate intake with vegetarians or chronic alcoholism sometimes. Or there may be malabsorption due to intrinsic factor deficiency called as pernicious anemia, or distal ileal resection will cause vitamin B12 deficiency. Or there is a increased demand for vitamin B12 that is seen in pregnancies. Coming to the folic acid deficiencies, inadequate intake with chronic alcoholism will result in folic acid deficiency. It is also required or there is increased demand of folic acid during the pregnancy. There may be impaired utilization with the use of methotrexates, which will hinder the absorption of the folic acid, thereby causing folic acid deficiency. Malabsorption due to anticonvulsants like phenytoins or OCP usage will show the effect of folic acid deficiency. Coming to the pathogenesis, vitamin B12 or folic acid deficiency will cause inadequate DNA synthesis. Defective nuclear maturation will lead to ineffective hematopoiesis. Along with this, vitamin B12 deficiency will also cause abnormal myelin degradation, leading to neurological complications. So, in the previous few slides, I have told the B12 metabolism. When we have taken a food consisting of vitamin B12, then it will bind with the protein molecules in the form of adenosylcobalamin and methylcobalamin. When it enters the stomach, the acid and pepsin will cause proteolysis and release the B12 from the protein. And this B12 will now combine with the gastric R protein that is secreted from the saliva and gastric juice, which has a greater affinity for B12 when compared to intrinsic factor, and thereby resulting in the formation of B12R protein. This R protein is also called as haptocorin. This will enter into the small intestine. With the help of the pancreatic enzymes, this B12R protein complex is cleaved, and further B12 is liberated. Now the intrinsic factor released by the parietal cells in the fundus and body of the stomach will form a complex with the B12. Intrinsic factor B12 now bind to the receptors on the brush borders of ileal mucosa in the presence of calcium, and when the pH is more than 6, that is almost alkaline medium or near to neutral medium. Then the intrinsic factor is destroyed in the ileal cells, and the B12 now will combine with the transcobalamin 2 and gets released into the portal circulation. So from there it is distributed to tissues as holotranscobalamin, and the cellular uptake of the B12 via megalin or transcobalamin 2 receptor complex will form. So simply remember, B12 can't move without any a transporter. So it has to bind with something to get transported from one place to another. So from mouth to stomach, the it will form complex with protein. From stomach to small intestine, it will form complex with gastric R protein, and from intestine, that is ileum, the stomach released already the intrinsic factor. This will carry the B12 and it is distributed to the portal circulation after the intrinsic factor is destroyed, and it will be carried with the transcobalamin 2, and it is transported or distributed to the tissues as holotranscobalamin, and further it is distributed into the cells using megalin or transcobalamin 2 receptor complex. So there will be derangement at any step that may cause to B12 deficiency. If only intrinsic factor is not available, then the anemia is called as pernicious anemia. So for succinyl-CoA from methylmalonyl-CoA, B12 is required. If there is no formation of succinyl-CoA, there will be increased levels of methylmalonyl-CoA because of the B12 deficiency, thereby causing abnormal myelin lipids, which will end up in neurological abnormalities and myelin degeneration, that is subacute combined degeneration of spinal cord, and they will show peripheral neuropathy symptoms. Because of the incomplete or non-formation of the DNA, because of the non-availability of DTMP, which has to be formed from the DUMP with the help of the folate, and because of the non-formation of the methionine from homocysteine because of the deficiency of methylcobalamin. Also, there will be megaloblastic anemia. Impaired DNA synthesis and trapping of folate as methyl tetrahydrofolate will also result in megaloblastic anemia. The polyglutamates with the help of the conjugases will convert to monoglutamates and further converted to methyl tetrahydrofolate with the help of reduction reactions and methylation. The DUMP has to be converted to DTMP to form DNA. So it is help thymidylate synthetase reaction will be there, which is blocked when there is folate deficiency. Coming to the clinical picture, we will have the symptoms of anemia, that is lethargy, weakness, pallor. There may be dyspepsia, glossitis with beefy red tongue, loss of weight, appetite, loss of appetite, diarrhea, mild jaundice. Vitamin B12 deficiency causes lower extremity spastic weakness and paraplegia, like the neurological symptoms tingling, numbness, weakness of extremities, loss of vibration and proprioception, loss of memory, depression, and irritability because of B12 deficiency. Because of the association with folate deficiency, there is increased risk of neural tube defects. Coming to the investigations, complete blood picture shows low hemoglobin, raised MCV, normal MCSC, and low reticulocyte count. Pancytopenia may be seen with low total WBC count and low platelet count. Here, pancytopenia is because of there is impaired DNA formation. DNA is formed from DTMP. DTMP is formed from because of the conversion of DUMP to DTMP, where folate is required. For succinyl-CoA to form from methyl-malenyl-CoA, B12 is required. For methionine to form homocysteine from homocysteine, B12 is required and folate is required. So there is a problem in the nuclear nucleus or DNA synthesis. So all the RBC, WBC and platelet counts will be decreased in a macrocytic anemia, that is megaloblastic anemia because of B12 and folate deficiency. There will be macrocytic normochromic anemia with the triad of macroovelocytes, Howell-Jolly bodies, and hypersegmented neutrophils. That is, neutrophil will have more than 5 lobes. If the neutrophils are having more than 5 lobes and if they are present around more than 5% of the total neutrophils, or if a single neutrophil is having 6 lobes also, it is characteristic feature of megaloblastic anemia. So this is a picture showing beefy red tongue, which is a classical feature of megaloblastic anemia. And in the upper peripheral smear picture, you will be able to appreciate the hypersegmented neutrophil, a Howell-Jolly body, basophilic stippling, and Cabot ring, and few macrocytes. And in the lower picture, you will be able to appreciate the myeloid cells and megaloblasts. So, in a peripheral smear, macrocytes and hypersegmented neutrophils are the characteristic features. Along with this, there will be marked anisopoikilocytosis Basophilic stippling will be there. Cabot rings will be seen. Howell jolly bodies also noted. There will be pancytopenia with hypersegmented neutrophils in a megaloblastic anemia peripheral smear picture. This is the picture showing hypersegmented neutrophil, Howell jolly bodies, basophilic stippling, Cabot rings, and macrocytosis. Classical features of megaloblastic anemia. In the bone marrow, there will be erythroid hyperplasia. There will be hypercellularity. Thereby, Me ratio is decreased. Erythroid precursors will show megaloblastic changes. In the megaloblasts are large precursor cells having large nuclei with open and sieve-like chromatin and relatively hemoglobinized abundant cytoplasm. Giant metamyelocytes and band forms will be seen. There will be large megakaryocytes with bizarre multilobate nuclei. Most precursors will undergo apoptosis. To understand simply, there will be erythroid hyperplasia. Here in megaloblastic anemia, B12 and folic acid is required for DNA synthesis. As there is problem in DNA synthesis, the cytoplasmic maturation is normal, whereas the nuclear maturation is lagging behind the cytoplasmic maturation. There will be nuclear cytoplasm asynchrony that will end up in the bone marrow and peripheral smear findings what we are observing. So in the exam, they will ask you MCQ, nuclear maturation lagging behind the cytoplasmic maturation is seen in option A, microcytic anemias, option B, megaloblastic anemias or macrocytic anemias, option C, normocytic anemias, D, none of the above. The answer is megaloblastic anemias or macrocytic anemias. If there is cytoplasmic defect, that is cytoplasmic maturation is lagging behind the nuclear maturation, then it is microcytic anemias because of the iron deficiency anemia most of the times. This point has to be remembered. Hemoglobin synthesis defect will cause iron deficiency anemia as iron is needed for the formation of heme, and thalassemias as there is defect in the globin chain synthesis. So this is a picture showing the megaloblast with which is a large erythroid cell showing nuclear cytoplasmic asynchrony. That is, maturation of the nucleus is lagging behind the maturation of the cytoplasm because of the impaired DNA synthesis caused by the deficiency of vitamin B12 and folic acid. Coming to the lab findings, the serum lactate dehydrogenase levels are elevated. There will be increased form aminoglutamic acid in urine after histidine administration. Serum haptoglobin, uric acid, and alkaline phosphatase are decreased. Serum and erythrocyte cobalamin levels are decreased in vitamin B12 deficiency. Serum and erythrocyte folate levels are decreased in folate deficiency. And Schilling test is useful in distinguishing the B12 deficiency due to malabsorption, dietary deficiencies, or absences of intrinsic factor. There will be serum bilirubin levels increased, serum LDH values increased, serum antibodies to intrinsic factors are present in pernicious anemia. Low serum vitamin B12 levels, elevated serum homocysteine levels, and methylmalonic acid levels is characteristic of vitamin B12 deficiency, and low serum RBC folate levels and raised serum homocysteine levels are the features of folic acid deficiency. Coming to the Schilling test, it is done. Schilling test is a definitive test useful in distinguishing the vitamin B12 deficiency due to malabsorption, dietary deficiency, or absence of intrinsic factor. This chilling test will be done in two stages. In the first stage, you will inject the B12 intramuscularly 1000 micrograms to saturate the transcobalamin 2, and then you will administer the oral B12, which is radiolabeled with cobalt 57 or 58. You can simply call the B12 which is not radiolabeled as cold B12, and the B12 which is radiolabeled with cobalt 57 or 58 as hot B12. And you have to wait for 24 hours, collect the 24 hours urine, and estimate the radiolabeled B12 values. If it is 10% or more in the urine, then it is normal. If it is less than that, then there is a problem. So in the second stage, again you have to inject the B12 intramuscularly 1000 micrograms to saturate the transcobalamin 2, same as in stage 1. Then you have to administer the oral B12 radiolabeled. Now along with the radiolabeled B12, we are adding the intrinsic factor. Again we have to collect the 24 hours urine, and you have to check for the B12 values. If it is less than 10%, again there is problem. If it is more than 10% or equal to 10% of the B12 values, then it is because of the intrinsic factor deficiency. Thereby, pernicious anemia is diagnosed. Again, in the third stage, you can do it by giving antibiotics, and again the procedure is repeated. If there is urine values of B12 normal, that is 10% or 8 to 10%, then you can consider there is a problem in the ileum, or there may be infection in the GIT. So this is a picture showing the schilling test. We are injecting the non-radioactive vitamin B12 intramuscularly, and which is called as cold B12, and radioactive B12 with the help of cobalamin 57 or 58, which is called as radioactive B12 is called as hot B12, is ingested, and the urine is collected for 24 hours, and we have to check the values of B12. So in a normal case, as the radiolabeled vitamin B12 is observed, there will be a negative test, that is 8 to 10% only is excreted in the urine in 24 hours. Whereas in pernicious anemia, because of the intrinsic factor deficiency or malabsorption, the radiolabeled vitamin B12 is not observed, which shows positive schilling test, that is less than 8% of B12 is excreted in the urine. This is step 1 or part 1. In the step 2, again oral radiolabeled vitamin B12, that is hot B12, and along with that we will give intrinsic factor orally, and again we will give in, intramuscularly vitamin B12 to saturate the serum B12 levels. And when we observe the radiolabeled vitamin B12 is observed is because of the intrinsic factor given from outside, and the test is negative, that is 8 to 10% is excreted in urine, then the anemia is pernicious anemia because of intrinsic factor deficiency. In the malabsorption case, Radioactive labeled vitamin B12 is not absorbed as there is basic defect in the absorption. Thereby, positive Schilling test will be there and there will be less than 8% of B12 radio-labeled excreted in the urine. So, in pernicious anemia, radioactive B12, that is cobalt 57 or 58, is reduced in pernicious anemia, chronic pancreatitis, bacterial overgrowth, and ileal disease. In all the conditions, the excretion will be decreased. When we have given orally along with the radio-labeled B12, if intrinsic factor is given and if the urine excretion is normal, then it is because of pernicious anemia. When we have given pancreatic enzymes and if the B12 excretion is normal, then it is chronic pancreatitis. And after giving antibiotics for 5 days and again we have checked and there is no bacterial overgrowth, then it is because of the bacterial overgrowth. If at all still the urine excretion is coming low, then it is ileal disease, problem in the ileum. In this way, Schilling test is useful to differentiate various causes that are causing the B12 deficiency. Whether it is because of pernicious anemia or chronic pancreatitis or bacterial overgrowth or ileal disease can be detected with the help of the Schilling test. Coming to the pernicious anemia, it can be asked for a 3 marks question or a 6 marks question. It is an autoimmune disease. Antibodies are formed against the parietal cells that are secreting this intrinsic factor. So antibodies against parietal cells intrinsic factor. Thyroid, myxedema and melanosomes vitiligo will all be seen in pernicious anemia. Will also show this pernicious anemia. There will be glossitis, there will be pallor and hematological features will be anemia, pancytopenia, megaloblastic hematopoiesis. There will be cellular bone marrow and there is ineffective hematopoiesis. Schilling test is useful in diagnosing and B12 levels and antibodies SS will also helpful in diagnosis of pernicious anemia. Treatment is giving B12 by IM injection, frequent and at first, then after lifelong monthly once. Coming to the folate deficiency, all the hematological features will be same as that of pernicious anemia and in folate deficiency there will not be any neurological findings which are seen in megaloblastic anemia because of B12 deficiency. This is a mind mapping picture showing megaloblastic anemias for a fast review. Folic acid deficiency is seen in pregnancy and in chronic alcoholics or if there is malabsorption or ileal resection or chronic Crohn's disease. Vitamin B12 deficiency and intrinsic factor deficiency will cause pernicious anemia and there will be parietal cell antibodies. Atrophic gastritis is seen microscopically. Vitamin B12 deficiency can also be observed in gastrectomy patients, ileal resection, Crohn's disease, hereditary intrinsic factor receptor deficiencies. And the complications of vitamin B12 deficiency will be peripheral neuropathy and subacute combined degeneration of the spinal cord. The peripheral blood film will show macrocytic RBCs and hypersegmented neutrophils, and there may be Havel-Jolly bodies, Cabot rings, and basophilic stippling. Bone marrow will show large number of megaloblasts and delayed maturation of normoblasts and granulocytes. Nuclear maturation is lagging behind the cytoplasmic maturation. Iron stores will be normal or increased. So these are all inclusion bodies: basophilic stippling, cabot rings, Abel bodies, and hinge bodies, which are comes as a DD for a reticulocyte. In megaloblastic anemias, you will be seeing basophilic stippling, cabot rings, and Havel bodies. So macrocytic anemia in a nutshell, MCV will be more than 100 femtoliters. The causes can be megaloblastic and non-megaloblastic. Megaloblastic is because of the folate or vitamin B12 deficiency. Non-megaloblastic causes will be alcoholism, liver disease, hemolytic anemias, myelodysplastic syndrome, and hypothyroidism. When there is a macrocytes in the peripheral smear, you have to advise a reticulocyte count. If it is increased and there is polychromasia and evidence of hemolysis, it is hemolytic anemia. When the reticulocyte count is normal or low, and if you see oval macrocytes and hypersegmented neutrophils, then it is megaloblastic anemia. If you appreciate round macrocytes and dyshematopoiesis, then it is because of myelodysplastic syndromes. And if you see only oval macrocytes, it can be because of liver disease or alcoholism or hypothyroidism. This is a picture that I have drawn for easy understanding of microcytic anemias and macrocytic anemias peripheral smear. There will be microcytic hypochromic red blood cells with pencil forms. There will be marked anisopoikilocytosis. The WBC counts are normal in count and the platelet counts are normal or sometimes increased in microcytic anemias. Whereas in macrocytic anemias, there will be macrocytes, ovalocytes, hypersegmented neutrophils, basophilic stippling, Havel bodies will be there. There will be decreased RBC, WBC, and platelet count because of impaired DNA synthesis, resulting in pancytopenia in macrocytic anemia. So, in the exam, they may ask you pancytopenia is seen in A. Microcytic anemia, B. Macrocytic anemia, option C. Both, option D. None. The answer is macrocytic anemia. Before concluding, I would applaud him for thinking out of the box. This is a picture where the question was given: draw a butterfly and label the parts in brief. The student has drawn the picture like this. He has drawn a brief, and in that he has drawn the butterfly. So my suggestion is, read everything carefully before you do anything. Don't just blindly write whatever you understand. First read the question and answer the question accordingly, because the way you do one thing is the way you do everything. So if you are hastily doing the things, you will end up in results that will be not useful for you in your future. So be conscious, read everything carefully before you do anything. That is, don't jump into actions. Observe, read, observe, think twice, and come into action. Thank you for your patient listening. Please like, share, and subscribe Dr. Ravichandra Official for more interesting videos.